and my dear colleagues. On behalf of Durg Bhilai Academy of Pediatrics, I extend a hearty welcome to everyone joining tonight's session of this PG Clinics organized by Durg Bhilai Academy of Pediatrics, along with the help of Zuventus. First and foremost, it is my absolute honor to welcome our distinguished speaker for today, distinguished expert for today's session, Dr. Balasubramanian sir, a very senior pediatrician, teacher of teachers, and former director Kanchi Kamakoti Child Trust Hospital, and our very own Dr. Naresh Motwani sir, Professor Sri Shankaracharya Institute of Medical Sciences, Department of Pediatrics, and President Durg Bhilai Academy of Pediatrics. Thank you, both of you, sir, for your valuable time. And a special welcome to our young presenter, Dr. Meenakshi Thakur, a third-year PG resident from CIMS Bilaspur. We look forward to a fantastic case presentation and a learning experience. Finally, a warm welcome to all the academy members, senior faculty, and postgraduates who have joined online. I request all the postgraduate students to please keep their video on and ensure an active participation for today's case discussion. Over to you, Dr. Meenakshi.
Thank you, sir.
Before we start, I have one request to make.
Yes,
I think this time Naresh is going to take the lead in the discussion with Dr. Meenakshi Thakur, and I will pitch in wherever I need to add anything. Okay, let the younger generation start interacting more for this case today. Okay, Naresh?
Yes, sir. Yes.
Okay, thank you for a change. Is there anybody else joining the discussion? Neither professor or faculty? This time you decided you will jump in. Am I right?
Yes, sir.
Okay, please go ahead.
Start.
Yes, Dr. Meenakshi, please go ahead.
Yes, sir. Good evening, everyone. Respected jury members. Today, I'm going to give a case presentation of a CNS case. First, general introduction. I'm presenting a case of 3-year-old female child, Preksha Thakur, daughter of Purushottam Thakur. She's a firstborn child of a non-contiguous marriage. She's a resident of Kuli, Sipat, Bilaspur. She's Hindu by religion and her informant is mother, which seems to be a reliable source of information. She was a previously developmentally normal child, brought with the chief complaints of first, inability to walk for the past 1 year, then difficulty in gripping the objects for the past 8 months, then abnormal movements of the body for the past 4 months, then inability to speak for the past 3 months, then difficulty in swallowing of food and fluids for the past 1 month. In history of presenting illness, she was developmentally appropriate till 2 years of age. Then she had attained walking at the 1 year, climbing stairs at 15 months, running at 2 years. Then she had insidious onset, gradually progressive walking difficulty for the past 1 year. Her parents first noticed that the child to keep their knees bent while walking, then followed by the ability to walk for the shorter distances only with some difficulty, then repeated fall while walking, then progresses to difficulty in the climbing stairs and wearing sleepers, followed by the progressive loss of ability to walk for the past 9 months. Symptoms worsened, leading to inability to stand and sit with support since 4 months. The child is now able to lie on a bed but unable to roll over or get up independently from the supine position. The child is able to turn the head sideways but with some difficulty. Then she also developed weakness in the upper limb for the past 8 months. Her parents noticed initially difficulty in lifting her arms above the head, then for combing her hairs, then followed by the inability to mixing food and feeding by self for the past 4 months. Then gradually she was unable to grip the objects firmly as she had difficulty in holding a tumbler or a pen when offered. She was able to move the upper limbs with some difficulty. There was no any asymmetry of the weakness noted or fluctuability of weakness noted. It was not associated with any history of trauma or recent immunization or fever. Then she also had a history of abnormal body movements presented 4 months back. First episode started as a GTCS type of seizure with 3 times frequency over an hour of 3 hours, associated with eye uprolling, frothing with mouth, involuntary passage of urine and stool, duration of approximately 1 minute of each noted while playing as told by the parents, followed by the post-ictal dullness. She was taken to the DH CBAT for the same and started on the AADs. Compliance was good until then the seizure was controlled after starting the AADs. There is no any history of any fever, headache, aura, or any head injury or perinatal insult is there. Then she has a difficulty in speech for the past 3 months, which was insidious in onset, which was initially noted by the mother to have a decrease in the number of words, approximately 50, while followed by the bisyllable speech only, and now she is unable to speak even a single word. Responds only by making a sounds and gestures by pointing. She also developed difficulty in swallowing of food and fluids for the past 1 month, which was insidious in onset, progressive in nature, and associated with excessive salivation. There is no history of any nasal regurgitation or fasciculations in tongue. After admission in our institute, she was on nasogastric tube feeding since then. Negative history. There is no history of any fever.
I think you can stop. You can stop
Yes,
at this
sir.
point of time. You can stop at this point of time. You have a very long history. Naresh, you start and then I'll pitch in. You can go to the first slide and start.
First, Meenakshi, first slide में जाइए. First slide, yeah. Inability to walk.
Yes, sir.
This first slide. Before that, yeah, you added here, of course, details are okay. 3-year-old female, right-handed female child, first born to non-consanguineous. The last line you written, previously developmentally normal child brought with chief complaints of.
Yes, sir.
So, how do you say the child was developmentally normal?
Sir, as per the age, she has attained all the developmental domains normal, sir. That has been mentioned in the developmental history, sir.
Can you elaborate few of the milestones which the child had achieved till then?
Sir, likewise for gross motor, if you are talking, she has attained the walking, sir, at 1 year. Then she even starts the climbing stairs at 15 months, sir. She had even started running also, sir. After that, the difficulty in walking started.
Child was climbing stairs by 15 months.
Yes, sir.
When do the child starts climbing stairs?
सर बाय दोनों फीट एक साथ स्टार्ट 12 मंथ्स में हो जाता है सर. 12 फिर उसके बाद 15 months then 18 months sir.
It's too early you're saying. Okay, other milestones, social, language.
Sir, in language she has attained even at 3 years sir, she can say the I, me and you, the 3 words things she have been saying, sir.
No, before 2 years, all the development milestones were normal, you mean to say. So,
yes,
you mean to say all the domains the child was absolutely normal before the onset of this problem?
Yes, sir.
Okay. Okay, we will see again next slide, please.
Okay, now, one minute. Now, a very good history. I must compliment you, Dr. Meenakshi, for a very, very comprehensive history. Go to the next slide. There are actually 5 complaints. No, previous slide. There are actually 5 complaints starting from some walking disturbance, then some upper limb problems, then abnormal movements, then speech disturbance, then feeding difficulty. Okay, so walking is affected, hand movements are affected, some involuntary movements are occurring, speech is disturbed, feeding difficulty is there. Okay, all occurring over a period of now 1 year. One by one new signs are appearing. Okay, right. There are 5 good symptoms you have pointed out. Very good. Next. Now, I'm extremely happy the way you had started. I must compliment you. You had clearly mentioned that this child was absolutely normal. Many students, while they are presenting, they will never mention what is the status of the child. you are clearly saying that this child was normal till 2 years, and you had. I like the way you had put it. She had insidious onset, walking difficulty, and I like the adjectives. I must compliment you. Gradually progressive. Okay, for 1 year.
Yes.
Okay, very good.
Yes.
Now the next sentence, I want you to tell me that long sentence like politician speech. Her parents noticed initially the child to keep her neck bent while walking, followed by ability to walk for shorter distances with difficulty, and repeated falls while walking, progressing to difficulty in climbing stairs and wearing slippers, followed by progressive loss of ability to walk past 9 months. Can you decipher what you had put so many things? What do you make out of this? You
Sir,
make
I
it
want
very
to know.
complicated. Yeah. How do you interpret
Sir, I
your
want to
long sentence?
notify, sir. Firstly, the proximal muscle weakness has been arrived. Later on, the distal muscle weakness has been there.
How do you know proximal muscle weakness were initially affected?
Sir, firstly, she had main difficulty in standing and all. And later on, in like wearing sleepers like that. So that's why, sir.
No, ma. The first symptom is she kept her knees bent. What do you mean by
Yes,
this statement? Bent inward or outward?
sir, inward, sir.
No. See, the knees can be bent inward or outward,
Yes, sir.
isn't it? Yes or
Yes, sir.
no?
Yes,
Were
sir.
they bent inward or outward? And why am I
Sir,
asking this question?
sir, Jain, you welcome and welcome for making a DD of rickets. You are asking, sir.
No, ma. Whenever you are saying child is developing progressive weakness, okay, there are two
Yes.
children with lower limb weakness. One child walks like this, crossed leg. Another child walks like this. What is your interpretation?
Sir,
You
if
get my
cross,
point.
that
See my
is.
fingers. See, one child walks like this. Okay,
Yes, sir.
one child walks like this
Sir,
with the
the
ankles
crossing
apart.
is that is called as the scissoring gait. So scissoring gait is a classic finding seen in CP, sir. So,
Okay, what about this?
sir, genu valgum, sir, like
No.
seen classically in.
Basically, if
Tone of
if there is lower limb weakness in anyone, if there is like this, it is likely to be spastic. If
Yes,
it is like this, it is likely to be flaccid. You understand?
yes, sir.
I hope you got my point. That you
Yes.
could have got. You could have got. Now going back, what did the parents say? It was like this or this like this?
So they have seen inward, sir.
Dr. Meenakshi,
Yes, sir.
you didn't ask. Okay, it's okay. It's okay. Doesn't matter. And she repeated falls while walking and progressing to difficulty in climbing stairs and wearing slippers. What is the problem with wearing slippers? Why do you think this child had difficulty in wearing
Wearing
slippers? What
slippers
does
is
it
asked,
indicate
sir.
to you?
It denotes distal weakness is there or not.
Yeah, distal muscles are involved.
Yes.
Distal muscles are involved. Okay,
Does
right.
2-year-old child, sir, I had one doubt, like a 2-year-old child, how often they wear slippers regularly? That too, she's from a village. And when did they notice? Is it sometimes or is it often, very often? Because, yeah, Meenakshi.
Okay, the child had, okay, right. Symptoms worsen leading to inability to stand and sit without support since 4 months. What does this sentence mean? The child is able to lie on a bed but unable to roll over or get up independently from the supine position.
Sir, it want to notify, sir, the truncal muscles had also been affected, sir.
Excellent. And why did you mention child is able to turn head sideways
The
with some
neck muscles
difficulty?
had also been affected, but not fully, sir.
Okay. Go to the next one. Next slide. Yeah, she also developed weakness in the upper limbs. Okay. Initially, what does it mean? Initially, Yeah, somebody is put Dr. Ashwini Agarwal putting his ascending direction paralytic situation. Fair enough. Her parent noticed initially difficulty in lifting her arms above the head for combing her hair, followed by inability to. What does it mean? What does this sentence mean?
Sir, initially there has been difficulty in lifting her arm. So, sir, basically her proximal muscles have been affected.
Yeah, proximal, then it is also involved the
then when combing also,
distal
it leading to distal also, sir.
Okay. She was able to move the limbs with difficulty. There was no asymmetry. Okay, very good. We do not associate with issue. Now, having said all this, I never heard anything about the tone of the limbs. Did you mention?
No, sir. On examination, it is mentioned, sir.
Is it? No. History, mother won't tell you.
What is the posture of the child when the child is walking, when the child is
Mother
lying
won't tell
down?
you. Mother won't tell you.
It is changing the wrapper or
Two
any
things
clothes
you
changing
should
the
have. Yeah. Yes, Naresh, what you're saying is right. The posture of the child and the tone of the child, the parents will clearly tell you whether the limbs were stiff or floppy. So that would give you a lot of information whether it is an upper motor neuron lesion or an upper lower motor. You should have asked. I'm sure, I don't know what you got later on examination. Don't worry about it. Okay.
Yes.
Right, next slide. Yeah. Okay. Now, what these abnormal movements are, ma? What are these movements?
Seizures are only.
Now, pardon? What abnormal movements are they?
Sir, generalized tonic-clonic seizures, sir.
Then why do you want to call them abnormal body movements? You call seizures as abnormal body movements?
So HOPI should be in patient language, sir. That's why.
The patient language is, see, one thing, ma, you must remember, patient's language, they may say something. But when you are interpreting, if you are sure it is seizure, say it is seizure.
Yes.
You don't have to say what the patients are saying. Right? Patients may say, oh, you are supposed to interpret. You can see convulsions or say seizures. This is convulsion, isn't it?
Yes.
Yeah. So instead of saying abnormal body movements, you could have said seizures. Okay. Right. Multiple seizures have been there, and she is on anticonvulsant therapy. Next slide.
One more thing, Meenakshi.
Yes, sir.
You have mentioned the child had difficulty in combing hair. The age is 3 years, and you're saying since last 8 months they have noticed that the child is having difficulty. So, do you expect a 2.5-year-old child to comb their hair? There may be other movements, na? Ki the child may have difficulty in holding an object, eating by self, or scribbling and all. That is fine. But you expect the child, 2.5-month child, to comb their own hair?
No, sir. At 3 years it is there. Yeah.
Naresh, nowadays 2.5-year-old child is asking for lipstick. Yeah, come on. So I don't think. Actually, my own granddaughter, 3 years, she's asking for lipstick. So I don't think it's not. I mean, it's okay, sir. That doesn't mean anything. She's indicating that
Just there are some
child
other
is having some proximal weakness.
distal
Okay,
muscles, right? Fine.
Fair enough. Okay, seizures, multiple seizures with an anticonvulsant. Next slide.
Next one.
Yeah. Now, what do you make out of this sentence, long sentence? Inability to speak. What happened? She has become aphasic or she has become dysarthric?
Aphasic, sir.
Aphasic. Okay, fine.
Yes.
Progressive aphasia. Then, difficulty in swallowing of food and fluids, which excessive salivation, no history of nasal regurgitation. What does it mean?
Sir, it is denoting that cranial nerve 9th and 10th is basically affected, but it can be upper motor neuron like cortical, and at the brainstem level also it has been affected. Can be same.
Bulbar weakness is there. That's what is. Okay, fine.
Yes.
Go ahead. Next. Yeah.
Then
Now,
negative histories.
see, avoid Dr. Meenakshi and PGs listening to this program. Don't use the term negative history. There is no such thing as negative history. You are only mentioning a few relevant points to rule out a few diseases or rule out a few causes for the present illness. And don't use the term negative history, positive history, all that. Okay, go ahead.
No history of any fever, loose stools, vomiting, ear discharge, or skin rashes. There is
What
no
is the
history.
significance of all of them?
Sir, any infectious causes there or not? Like ear discharge.
Okay. No history of fever. You mean to say 1 year history? Why do you want to talk about diarrhea? What disease do you think of when you mention diarrhea?
Sir, due to diarrhea, electrolyte disbalances like severe hypokalemia, so it can be
Will
presented
it
as
cause problems over like this over 1 year? See, you must realize history should be relevant, should not be irrelevant. That is totally irrelevant. Don't talk about loose stools, vomiting, ear discharge, skin rashes. I think you have put it first. They have no relevance in this case, which is chronic.
Yes.
And 3-year-old child headache, will it complain? 2-year-old child? The story started at 2 years. How many children have you seen at 2 years with headache? Have you
No,
seen
sir,
any case?
No, sir.
Removed. Abdominal distension, icterus, why?
Sir, hepatic encephalopathy.
Hepatic encephalopathy, 1 year duration. Is it hepatic encephalopathy? Again, this is what is the problem. Sorry, don't think I'm angry with you. I think history should be very clear. Hepatic encephalopathy, 1 year history. No question at all.
See, you yourself have said it's an insidious, chronic problem.
Yeah. Abnormal pigmentation, okay. Hair, skin changes, okay. You're thinking of some metabolic disorder, right?
Head
Head
size is
size
fine.
has been normal, very good. Abnormal face is good. Odor of urine. Which disease did you think of when you asked for odor of urine?
Sir, maple syrup urine disease or like phenylketonuria we are ruling
Will
out.
the child be completely all right up to 2 years in maple syrup urine disease?
No, sir, but from infantile only
Then
at present.
see, that's what I'm saying. You should not bring in irrelevant things. And abnormal posture and contractures. Is this child not having an abnormal posture now?
No, sir.
No. Baby child is bedridden, unable to get up from bed.
Yes, sir,
So
but
contractures, okay. Deformities, okay. No history. See, again, you started
Involuntary
with the
movements.
statement that the abnormal movements. Now you are saying no history of involuntary movements.
You can say
sir,
other involved. Other involved.
Abnormal movements. How are they different? How are they different from involuntary movements? You mentioned voluntary movements are abnormal. Again, see, be careful about negative history. Negative history should be really focused. Okay, I agree with you. The important points are abnormal pigmentation, hair, skin changes, head size. Okay, that's all. Rest all is absolutely meaningless history. The only other history I would have elicited is weight loss in this child. Why? Why is that important?
Sir, weight loss?
Weight loss, yeah.
Like, sir, in the cases like we are suspecting HIV encephalopathy like that?
Correct. A chronic infection like HIV can have a weight loss. Okay.
Yes.
Right? Even a degenerative disease may be associated with weight loss because of poor intake. That is more important. Okay. Next slide.
Yes.
Next slide. Abnormal smell. Which disease did you think of? What are give some examples of abnormal smell which will give you diagnosis in the nervous system? Give examples of smell. Anybody can put it in the chat box also. Abnormal smell giving a clue to the CNS disease.
So, like anosmia in the cases of COVID cases, sir.
Chronic hepatocellular failure can have fetal hepaticus. Very rarely. Okay, right? Other than that, I don't think any smell itself is going to give you diagnosis. In chronic uremic encephalopathy, you may get urine-like odor from the patient.
Yes.
Right? Okay, go ahead. Visual, no history of visual disturbance. Okay. Hearing disturbance. Okay. Exaggerated response to sounds. Not do. What did you think of? Why did you ask that?
Basically, sir, 8th nerve is affected or not, I want to check, sir.
Hyperacusis, okay.
Yes.
Positive history of difficulty in swallowing. Don't use the word, again, don't use the word positive history. There is difficulty in following with the pooling of secretions. Okay, please go ahead. And the tone, I'm sure the mother would have told you the limbs are becoming floppy or stiff?
Floppy, sir.
Floppy, okay.
Yes.
Go ahead, next.
There is no history of any deviation of tongue. The child was able to...
Why did you ask?
Sir, basically checking for the 12th cranial nerve, sir.
Okay.
Then the child was able to perceive the sensations such as hot, cold, pain, and touch. There is no history of any tremors on reaching for the objects. There is no history of any increased frequency of voiding or the urinary retention. There is no history of any excessive sweating, sir.
Go ahead.
In past history, no history of any recent immunization, trauma, or drug allergy.
What is the definition of recent immunization?
Sir, if recent immunization has been there, now I want to check out whether it is traumatic neuritis or not.
No. What is the definition of recent immunization? Can anybody put in the chat box? When do you use the term recent immunization? 2 weeks. As per the AEFI protocol, you are supposed to report all adverse effects within the 2 weeks of the administration of any vaccine. So recent immunization is a term which you should use if any immunization before the start of the illness had been given in 2 weeks' time.
Yes.
Okay, good.
Meenakshi,
Yes, sir.
did you inquire about other behavior of the child, like autistic behavior, communication? How does the child indicate the need? Whether the child is playful, or other repetitive
She's
movements?
responsive to her mother only, sir, by just pointing or gestures only, like crying only.
Now, how is the child's behavior towards other children? When the child sees other children, this is a contact, eye contact. How is the eye contact communication? I mean to ask about autistic behavior.
No, sir, there is not.
Why I'm asking about autistic behavior? Which conditions you want to rule out in a girl child?
Rett syndrome, sir.
Yeah. So, because the age of onset typically falls after around 2 years of age, female child, a regression of milestones. So, that is also important to ask about. Okay.
Yes. In antenatal history, her mother is primary, 22 years old, booked and immunized. There is no history of any decreased fetal movements or quickening in the first trimester. She has
essentially normal, isn't it? Normal antenatal history. Skip it. If it's normal, don't worry.
Yes.
Go to the next.
Natal and postnatal history is also
anything relevant?
No, sir.
Normal. Skip it. Next. To save time. Yeah.
Yes. So then developmental history. For the gross motor, till now, rolling over has also been absent and she has been not able to sit without the support. So the developmental age is 6 months with the DQ 16%. For fine motor, she is able to reach for objects and can change from one hand to another. So the developmental age is 9 months with DQ 25%. For social and adaptive milestones, she can recognize the mother and stranger anxiety has been there. But she cannot able to feed by self and all. So the developmental age is...
1 minute. At what age does a normal child reach for objects and changes from one hand to another? Is it 9 months?
It's not 9 months, no? Yeah. 5 to 6 months it should be, no? By 6 months. It's around 6 months.
4 to 5 months itself, the baby will start grasping objects and transferring objects from one hand to another. Not 9 months.
5 to 6 months at the most, you could have said.
Yeah,
and even the rolling over is said it is not, child is not having rolling over now?
No, sir.
So then why do you say 6 months?
Sir, she is not able to sit with support. करके सर मैंने 6 months उसको डाला था मतलब.
You said not able to sit without support. Is the child sitting with support?
You also said the baby is not able to, child is not able to roll over.
So it should be less than 6 months then.
Correct.
So she can rolling over is absent, sir, but she can sit with support, sir. So
But
that is it.
what does it mean that the child is having an age of 6 months?
Sir,
Then
at 5 to 6 months is occurred the tripod position. That's why I have put, sir.
what happens sometimes the child may not be having development age of 6 months, but still able to roll over or sit also. So
Right.
what are the situations? Suppose the child is starting rollover early 3 months. Does it mean it is actual 3 months or it may be something else also? What could be the reason sometimes? Tone abnormalities, no? Hypertonia. If the child is having hypertonia, child may have early rollover like that, something like that. So it is not an actual developmental milestone. Okay, so tone abnormalities you may feel that the child is started getting rollover, but it may not be. So similarly, sitting child is not able to roll over, but child is able to sit with support.
Yes, sir.
So it may be because of the tone abnormality. So in a particular posture, the child may be to otherwise it is not. It may not be actually achieved actually.
Yes.
Okay.
For
Then
the language,
social and adaptive recognizes mother, stranger anxiety plus not able to feed self, 6 months. Okay. Language able to produce sounds, 3 months. Only cooing, that's it.
yes, sir.
Not even
No
bisyllables.
bisyllables or unisyllables. All has been lost.
Okay. So what is this child having actually?
So neuroregression, sir. Matlab, loss of previously all the acquired milestones has been lost, sir. So it indicates the neuroregression or the neurodegenerative disorder, sir.
Okay.
What are the qualifiers to conclude that a particular child is having neuroregression? Can you tell me what criteria should be there to use
Sir,
a term called neuroregression?
फर्स्ट ऑफ ऑल सर द लॉस ऑफ माइलस्टोन इट शुड बी प्रोग्रेसिव सर मतलब जो रेट होना चाहिए सर लॉस का वो डेवलपमेंटल डिले मेन रहता है सर डेवलपमेंटल डिले और न्यूरो रिग्रेशन को डिफरेंशिएट करना होता है सर डेवलपमेंटल डिले में जैसे रेट ऑफ एक्विजिशन जो रहता है दैट इज स्टैटिक इट इज डिलेड while in neuroregression it is completely declining sir.
Okay, can any student put in the chat box? There are 3 criteria which should be there in any child to be labeled as having neuroregression. Can any PG put in the chat box the 3 criteria? In fact, the terminology is changing, Dr. Meenakshi. The British Pediatric Neurology Association has now changed the term from neuroregression to a new term called PIND, P-I-N-D. Progressive intellectual and neurological deterioration. It's called PIND. And there are 3 criteria which should be there. 1, there should be a period of normal development before the onset of symptoms. It is there in this child or not?
Yes sir, normal.
1. 2, there should be arrest of development and progressive loss of
already
acquired milestones. First thing to take place is arrest of development. That is followed by progressive loss of acquired milestones. Third, all these criteria should be there for at least 3 months. That is, whatever symptoms that are there, they should be there at least for a period of 3 months. And a few conditions are ruled out. One is something like an autism spectrum disorder or Rett syndrome. Second is an infection. For example, a child with neurological problem like a tuberculous meningitis may stop progressing, may stop acquiring new milestones and may regress. You don't call it as neuroregression.
Nice, sir. It is
Should
pseudo-regression.
not be due to infection or trauma or due to bullying or due to a psychiatric disorder. For the sake of PGs, I am repeating, 3 criteria should be there. First one is documentation normal development. 2, arrest of development and loss of acquired milestones. 3, it should be at least 3 months duration, and excluding near drowning, bullying, autism and Rett's disorders, okay, traumatic brain injury, etc. That is the definition of neuroregression as per the latest British Pediatric Neurology Guidelines. Does this child satisfy all the criteria, Amma?
Yes, sir. It satisfies.
Yes, absolutely, absolutely. Isn't it? Next.
What is pseudo-regression?
Sir, in pseudo-regression, there is not arrest of achievement of arrest or delay in the rate of declining, sir. Like the sir said, sir, like in the cases of TB or if any infectious cause is there, there is some for some time only the loss of the previously acquired milestones has been there. Like after that infectious time, again the developmental milestones has been achieved. So that is what called, sir.
Can you give some examples of pseudo-regression?
Like, sir, if a case of CP is there, he has been infected for some time of day. At that time, infectious anything. So at that time, he is not able to perform the previous milestones, sir. So we will consider it as a regression only, pseudo, sir. And later on, after the infection has been settled, the normal development which he have been acquired, it has been there, sir. So that is a example.
You have better examples, no? Like in child with cerebral palsy. Okay. So sometimes, no, they initially they roll over because of the increased tone, but subsequently, once the spasticity is there, they lose that. So you think that the child has lost that milestone. Or sometimes new onset tremors, dystonia, they can interfere with the child's locomotion. So actually, the brain has matured, child has not regressed, but because of that involuntary movements or dystonia, the child is not able to walk. Or sometimes parental misconception also can cause that. Or sometimes vision or hearing loss also can cause the child may lose the ability to speak like that. So these are some of the conditions. No, the child, you feel that the child may have regressed, but actually they are not. Okay. Next.
The nutritional history. The child was exclusively breastfed till the 6 months of age. Complementary feed was started at the 6 months and continued breastfeed till 2 years of age has been there. At present, her calorie intake for the 24 hours is 1000 kilocalorie with a calorie deficit of 19.35. Her protein intake was good 20 with a protein deficit of 9.99. Immunization history: immunized as per the age. BCG scar has been there. Family history, insignificant. There is no any history of similar illness or seizures or developmental delay or any sudden death in the family. No history of any recurrent sibling death is there. Socioeconomic status. According to the modified Kuppuswamy scale, her family belongs to the upper lower class 4th. In summary, my patient Preksha, 3 years old female, firstborn of a non-contiguous marriage, who was a developmentally normal child with uneventful neonatal period, immunized up to the age with no significant family history, with poor nutrition, presented with inability to walk since 1 year, difficulty in gripping the objects for the past 8 months, and abnormal body movements for the past 4 months, and inability to speak since 3 months, with some difficulty in the swallowing of foods and drooling of saliva. So she presented with insidious onset of a neurological problem, loss of the previously acquired milestones with seizures for a past 1 year. So probable this is a case of neurodegeneration.
Very nice summing up. I would like you to improve on in a few areas.
Yes.
One again, don't use the term abnormal body movements. This is seizures, isn't it?
Yes.
Once you're sure it is seizures, remove the term abnormal body movement. My next question is, I agree that this fulfills the criteria of neuroregression, right?
Yes.
If this is neuroregression, I would like to ask you, which are the areas in the nervous system are involved in this child?
Sir, as seizures has been there, so our cortex has been involved. Then due weakness, swallowing of food and drooling of saliva that's been affected. Definitely brainstem part has been affected. With the cranial of 9 and 10 we can expect. And inability to speak, matlab aphasia is there, so the speech centers like we can think so. And if we're talking about the motor system proximal and weakness both have been affected, sir. So our whole upper motor neuron has been affected, sir, there.
Why do you say it's upper motor neuron? That's why I asked you about the tone. What is the tone? What is the tone of the child?
The tone of the child is hypotonia, sir.
No, from the history, tone was increased or decreased?
Tone is decreased, sir.
Tone was?
Decreased, sir.
Decreased.
Yes, sir. In the lower limb, the tone is decreased, sir.
Then why do you say it's upper motor neuron?
Sir, other symptoms like the speech ability, the swallowing of food.
That doesn't mean it can involve the lower motor neuron plus upper motor neuron. Both can be affected, isn't it?
Yes.
You can have a disease which involves both the upper and lower motor neuron. Yes or no?
Yes.
Yeah. Okay. Okay. But then you can defend yourself by saying in diffuse cortical involvement, if there is subcortical involvement, it is usually spasticity. If there is diffuse bilateral cortical involvement, it can result in what is called cortical hypotonia. For example, even in cerebral palsy, in a minority of children, in the initial stages, in the first year or two, the infant or the young child may have floppiness, may have hypotonia, resulting in pediatricians labeling them as having atonic diplegia, in spite of having brisk reflexes and extensor plantar, and cognitive impairment. They may later develop hypertonia after 1 or 2 years of life with spasticity. The term that earlier pediatricians used to use for such cases was atonic diplegia. That term is no more used. It has been replaced by a peculiar term called cortical hypotonia, where even in a central lesion, upper motor neuron lesion, you can have hypotonia. But in this child who has so much of intellectual deterioration with aphasia, with lower cranial nerve weakness, in all probability, this is likely to be a cortical hypotonia rather than a lower motor neuron lesion. In case you had a history, did you inquire about the pain sensation in this child?
It is intact, sir.
Yeah. From the history?
Yes, sir.
Did you mention it?
Yes, sir. Mention, sir. She can able to perceive.
That's very important. That's very important. Yes. That makes a sensory disturbance and a lower motor neuron lesion unlikely. Okay. Now, if this is neurodegeneration, okay, the next question that I'm tempted to ask you, is this neurodegenerative disease a gray matter one or a white matter one?
Sir, it is actually the seizures main component has been there, so it is a gray matter one. But
gray
sir,
matter.
after yes, gray matter.
Okay, can you tell me what are the differences between a gray matter degenerative disease and a white matter degenerative disease? First of all,
Yes,
you
sir.
tell me what is gray matter, what is white matter?
सर व्हाइट मैटर दैट मीन्स अपन माइलिनेटेड जो न्यूरॉन का पार्ट होता है वो सर, और ग्रे मैटर में सर उसके जो सेल बॉडीज होते हैं वो होते हैं सर एक्सॉन्स के.
No, I don't understand Hindi, Dr. Meenakshi. Sorry.
सॉरी सर.
Habits die hard. I don't
Yes.
understand. Naresh knows. Okay,
Sir,
right.
so white matter constitute of a myelinated part of the neuron, sir, while gray matter the non-myelinated the cell body, sir.
The simplest
then
way
talking,
students can understand the difference between gray matter and white matter
so myelinated or
is as
non-myelinated.
follows. One, gray matter is like your TV towers antenna. White matter is your underground or rooftop cable. Okay, that's the best way to. The neurons are the gray matter, whereas the fibers are the white matter. Actually, strictly speaking, they are not really gray. It is actually grayish yellow, right?
Yes.
And white matter is strictly not white, right? Though it is called gray matter and white matter, right? The fibers are all white matter, the neurons are all, glial cells are all gray matter, right? Can you tell me, list out the important differences between
Yes, sir.
a gray matter degenerative disease and a white matter degenerative disease?
Yes, sir. In white matter degenerative disorder, sir, the main symptoms like motor symptoms like ataxia is there, or neuropathies like optic neuropathies are there. While in gray matter, sir, our cognitive defects has been more there, seizures has been more there, and in optic findings like pigmentation, retinitis pigmentations, or cherry red spot has been more there, sir.
Anything
Which
else?
problem has spasticity early? White matter or gray matter? Which condition shows early spasticity?
White matter, sir.
Yeah, so white matter disorder, early spasticity, they may have optic atrophy, and also the head size may be large sometimes. Whereas in gray matter, the head size usually microcephaly,
Small,
maybe normal
microcephaly,
also, but microcephaly, seizures, dementia, and all this. Later on, they may have spasticity, later stages.
Okay, go ahead with the physical examination.
Then examination, sir. On general examination, the child is awake, lying supine with shoulder in adduction, elbow inflection, and wrist in palm inflection, hip inflection and adducted, knees inflection and ankle in neutral position. She interacts with mother by sounds and gestures. There is no presence of any pallor, icterus, edema, lymphadenopathy, cyanosis, or clubbing. The vitals are normal, sir.
Okay, before, no, wait, go back. Again, I have been telling this repeatedly. Pediatricians should always describe the general appearance of the child. Whether the child is well looking or ill looking, undernourished or well nourished or obese, and what are the arresting or alert signs. In fact, more important, and you should have mentioned the nutritional status right in the first sentence. Is the child ill looking?
Ill looking, sir.
Are you chronically ill looking or acutely ill looking?
Chronically, sir.
Yeah. Is this child oriented in time and space and person?
Not,
Is
sir.
a 3-year-old child. Normally, a 3-year-old child should recognize the doctor, isn't it?
Yes.
As,
She has stinger anxiety.
so you could have mentioned all that. In addition to the posture of the child, she is not oriented in the time and space. She is not interacting with me. She has a vacant look. Does she recognize the parents?
Yes, sir. She recognizes mothers.
Yeah, that you can mention. Did she have stranger anxiety with you?
Yes, sir. Yes, sir.
Those things you could have mentioned in the initial statement. Go ahead.
Overall, by the attitude of the child, posture, what do you think is the child is having problem? Tone. What tone
Sir,
abnormality is there?
hypotonia, diplegia is there, sir.
Hypotonia?
Diplegic. In the lower limit is hypotonic, sir, but in the upper limit is normally, sir.
See, you mentioned shoulder in adduction, elbow in flexion. Okay, where do you get that?
Do you get adducted hips in hypotonia or abducted hips in hypotonia?
No, the position you have mentioned is child is having hypertonia.
Correct. You're right. Dead right, Dr. Naresh. You got it correctly.
Sorry.
Go ahead.
Yes. Then anthropometry. Weight for age is 10 kg and it lies in between -3 to -2 standard deviation, suggesting of underweight. While her median circumference is 14 centimeter and weight for height lies in between -2 to -3 standard deviation, so suggesting of moderate malnutrition, sir. Then on head to toe examination, her head appears to be normal in shape, hair appears to be normal, no facial dysmorphism or dysmorphic face is seen, eyes or ear appears normal, oral cavity also normal, no any chest deformity, trunk appears to be normal in appearance, on skin no hypo or hyperpigmentation has been there, no any bed sores or contractures seen, no neurocutaneous markers has been there, BCG scar is present there.
1 minute only. Is the hair sparse?
No, sir.
And depigmented?
No, sir.
To me, it looks like a blonde hair. Naresh?
No, sir. It is normal black hair.
Maybe because of the light or maybe.
Okay, fine.
Yeah, what are the, you said no facial dysmorphism. What are the conditions you can make out by looking at the faces of the child? Any examples?
Like, sir, dysmorphic faces we can see in the mucopolysaccharidosis, sir. The coarse faces we want to check out.
Then, any treatable condition you can make out by looking at the face with global developmental delay? Treatable. Anyone? Hypothyroidism, yes. Right?
Good.
Okay. Next,
go ahead.
please.
In examination of the nervous system, first the higher mental function. She is awake and conscious. Handedness present, right-handed. She recognizes the mother and interacts by gestures and sounds. Speech aphasia has been there. There has been no emotional disturbances or sleep disturbances is there. Then on cranial nerve examination, for the first is intact. For the second, she is able to fix and follow the objects and able to follow the bright color objects. And for visual field, she follows the light by the concentration method. Fundus appears to be normal with no any atrophic or pigmentation changes seen. For third, fourth, and sixth, the pupil appears to be normal in size. Direct and light reflex, indirect and direct light reflex has been present. No any nystagmus, squint, or ptosis has been there. For fifth, she is unable to chew the food, and there is no deviation of any jaw seen. Corneal reflex present, conjunctival also present, but jaw jerk brisk is there. Then for 7, no facial deviation has been seen. Other rest test can't be elicited. For 8, she is able to turn towards the sound in response to voice. For 9 and 10, uvula is in midline. The gag reflex has been preserved. For 11, she has been able to turn the sideways, but with some difficulty. For 12, she has been no tongue deviation or no any fasciculations has been seen there.
So which cranial nerves are involved in this child?
So 5th has been there, like Georgia brisk has been there. So that is representing actually upper motor neurons, sir. And rest are normal only, sir.
Okay. Fundus?
Fundus normal, sir.
Okay, go ahead.
What are the clinical clues you get by looking at the eyes? It may give important clues towards certain conditions. Can you name few?
Sir, in eyes, like if KF ring has been present, so we can check for the Wilson's disease. If
Very
any
good.
pigmentary changes like optic atrophy can be there, so we can go for the white matter disorder, sir, or any cherry red spot, or like retinitis pigmentosa has been there, so we can go for the gray matter disorder, sir.
Okay.
Yes.
Nice. Even ataxia, telangiectasia, look for telangiectasias if you are having
Yes,
those
sir, yes.
children. Cataract may point towards Wilson or galactosemia, like that. Okay.
Yes.
One doubt I have, you said right-handedness.
Yes, sir.
This child is having so much of neuroregression. You said the child's age is around 5 to 6 months. Will the handedness be preserved at this 6 months? Right-handedness, you said.
But sir, whenever I am performing it, she is continuously having that prominence only, sir.
It may be the child is not able to move because of the weakness, or maybe because of the spasticity.
But sir, in both upper
Definitely.
limb, by examination, the power and tone that has been equal only, sir.
Okay.
What is the normal development of handedness? Number one. Number two, when do you use the term premature premature handedness? Three, what are the conditions in which you get premature handedness?
Sir, handedness usually appears at 18 months, and it can develop up to the
18 months to 2 years.
Yes, sir. 18 months to 2 years.
1.5 to 2 years it takes. That's
Yes,
the
sir.
correct answer.
Yes, sir. And
Then
before
what's the
18 months,
significance? What's the significance? Why should you know the handedness of any child in neurology?
yes, sir, that is early hand preference before the 18 months or up to the 12 months. That is what called, and it is most commonly seen in like CP syndrome.
No. Just wait.
Yes, sir.
Though development of handedness takes place by 18 to 24 months, premature development is restricted to the development of handedness below 12 months of age, by and large. If you find that below 12 months in infancy, a child develops handedness, that is called as premature handedness. What are the conditions in which you get premature handedness?
Like CP only, sir, the best example.
Other than CP? Suppose handedness had occurred early and the limb is floppy, upper limb, large baby, normal delivery, difficult delivery, breech delivery. I'm giving a lot of clues.
Any
Anybody
particular
can-
position of the hand you look for?
Brachial plexus injury, any brachial plexus injury or fracture with contracture of an upper limb due to neonatal birth injury or congenital hemiplegia due to cerebral palsy may cause premature handedness, which can be an important clue. Right? And the
Yes.
other important point you must remember, a right-handed individual, the speech area is there in the left cerebral hemisphere, but for a left-handed individual, 50% have in the right, 50% have in the left, the speech area. It's important because if a right-handed individual develops a stroke due to a lesion in the left cerebral cortex, speech area may be affected. Whereas if it is a left-handed individual, if there is a left hemispherical lesion, aphasia might not occur. That is the importance of handedness in neurology. Go ahead.
Then for motor system examination, first nutrition, there is no any obvious atrophy or wasting of the muscle seen. For upper limb, the symmetrical distribution has been there, as well as for the lower limb also. For talking about the tone, for the upper limb, both for right and left limb, the tone appears to be normal, but for the lower limb, it is hypotonic. Then for the power, checking for the neck muscles, she is able to turn the sideways with some difficulty. In supine and prone, she is unable to lift the head of the bed. For abdominal and the trunk muscles, she is unable to side by side. Then for the upper limb, overall the power lies in between 4/5, while for the lower limb, it lies in between 2/5. Here is the detailed.
Upper limb 4/5, 4/5. I'm surprised.
Yes, sir. She's having.
Okay, fine. Anyway, I can't check.
What did you do to check the power upper limb?
Sir, I have checked. मतलब resistance से वो पूरा कर रही थी सर.
She was obeying your commands?
Yes, sir. मतलब हर मदर को मैंने बोल दिया था तो she has been obeying, sir.
Really, you said developmental age उसका कितना है इसका?
मैं 6 months बोला है सर मैंने.
See, which 6 months old child will oblige your commands?
A 6-month-old baby will how will still you can check the power. How will you check? Suppose I want to check the power of the lower limb of a 6-month-old baby. What will I do? She will not obey. The child will not obey your commands. But something you can do. When you child to flex and extend the limb, no, sometimes the child cries and child may push your hand. So that resistance, no, you can feel. The child may push your hand. So that resistance, if it is good enough, then you can say, okay, against gravity, the child is able to push your hand. So it may be 3+ or 4+ like that. But otherwise, it is very difficult, no? Okay?
Yes.
Go ahead.
Then for the reflexes, for the superficial reflexes, the corneal, conjunctival, abdominal, as well as pharyngeal reflexes has been intact. The plantar reflex is extensor there. Then for the DTR, the biceps and triceps has been there, present with +2. For the knee jerk and ankle jerk has been only +1. Sensory
Any
system.
clonus? Any clonus?
No, sir. No any clonus, sir. Sensory system has been
abdominal reflexes?
Intact, sir.
Jaw jerk?
Jaw jerk brisk, sir.
Okay.
Sensory system intact, sir. There is no presence of any cerebellar signs, no any pendular knee jerks, or no intentional tremors or nystagmus has been there, sir. No any signs of any autonomic instability. On spine and cranium examination, normal, sir. No any signs of any meningeal irritation, sir.
Okay.
What is the head circumference you said? Head circumference, I forgot. How much it
sir,
was?
Normal, sir, it lies in between -2 to -1, sir.
Okay.
Yes. Then another system, normal findings, sir. CVS में S1, S2 heard, no murmur heard. On respiratory system, bilateral air entry present, no any respiratory distress. On parabdomen also, normal in shape, no any distension. And on palpation also, no hepatosplenomegaly has been there. Liver span has also been present with 8 cm with no shifting dullness. On auscultation also, vowel sounds has been present with no brute or venous harm is there. So my provisional diagnosis is, this is a case of a 3-year-old female with a neuroregression suggesting of neurodegenerative disorders involving our both gray matter as well as white matter disorders with moderate malnutrition, with seizure, with hypotonia. So my differential diagnosis, the most probable is the metachromatic leukodystrophy. The other are the adrenoleukodystrophy, the neuronal steroid lipofuscinosis, and the Niemann-Pick disease and the mitochondrial disease, sir. And this is supported by this investigation, sir. On the MRI findings, sir.
No, wait.
Yes.
Back.
Wait.
Why do you say mitochondrial disease?
Sir, in mitochondrial disease, both our white matter as well as gray matter together, if combination, so that is the best.
No. Mitochondrial involvement, it is usually multi-system involvement. Okay. So first you have to make it key. You are dealing with only CNS or some other system is involved. If it is CNS, only central or even peripheral. I mean to say ki central or peripheral, both are involved.
Yes,
so
sir. Yeah, both are involved. Yes, sir.
Is it only nervous system is involved or any other system is also involved in this child?
CNS and peripheral nervous system is also only involved, sir.
पेरिफेरल नर्वस सिस्टम. सो पेरिफेरल नर्वस सिस्टम इन्वॉल्वमेंट का क्या साइंस है आपको इसमें?
सर मतलब हमारी पूरी फाइंडिंग जो है वो अपर मोटर की तरफ आ रहे थे सर, लेकिन जो डिस्टल वीकनेस का आ रहा था वो हमारे लोअर मोटर की तरफ जा रहा था.
Hindi, please stop Hindi. I don't understand. Thank you.
Sir, like many findings are suggestive of upper motor neuron only, sir. Like our plantar extensor has been there. Well, only one significant finding, that is hypotonia, that is leading to lower motor neuron, as well as the distal weakness has been there, sir. So our peripheral
Suppose the child is having hypotonia.
Yes, sir.
But reflexes are normal or brisk. What does it mean?
Sir, it can suggest the involvement of our both white matter and gray matter, sir, both.
See, your peripheral nervous system is not at all involved in this child if your reflexes are present. So if you're having a child who is having peripheral neuropathy, for example, you are saying both central and peripheral is involved. So your reflexes should not be elastable at all.
So, but it is diminished, sir.
And
Like
your
our
tone,
DPR and knee jerk has been just +1 only, diminished.
that can happen in central. In central hypotonia, sometimes what will happen? The reflexes will be preserved. Your plantar may be upgoing. Okay. Here
Yes.
in peripheral neuropathy, what will happen? Your plantars will not be elastable. Your deep tendon reflexes will be suppressed. They'll be absent usually. Okay. Tone may be hypotonia, of course, like that. Okay. So, okay. So this is one. Mitochondrial involvement, differential diagnosis. Usually it is a multi-system involvement. But here you have mentioned only CNS involvement. So adrenoleukodystrophy, age of onset, I have doubt regarding adrenoleukodystrophy. How do they present?
It is more, sir, it is X-linked inheritance, sir. So it is mean with boys, it is present. So it is female child to distinguish, sir. And also it will present with the signs of adrenal insufficiency, sir, like any pigmentation or hypopigmentation.
Does the child have any of these?
No, sir, no, sir.
So why you put it in the first one? सबसे पहले आपने you have put it in the first differential diagnosis. So in the order of preference, you should put your differential diagnosis.
Yes.
ठीक है. Adrenoleukodystrophy usually age थोड़ा सा school going child और थोड़ा older child they present. They may have these features you said of hypoadrenalism. They may have some skin changes also. But first differential diagnosis
First will be MLD only, sir. Yes.
MLD you can put little higher up.
Yes.
NCL and MLD, what is the difference?
Sir, NCL is basically a gray matter disorder, while MLT is mainly a white matter disorder. Sir, in MLT, our both, sir, it has two presentation, infantile as well as juvenile. But mostly the symptoms, like the three main things, like if normocephaly, if any seizures has been there. So this main points are distinguishing for NCL and MLD, sir.
See, in MLD, usually seizures may occur later because it is mainly a white matter disease, right? So spasticity may be there. Okay, your optic atrophy may be there, but seizures usually occur later. Okay, in MLD. And neuronal cerebral hypotension is a gray matter disease basically. Okay, so the head size is normal, so it may go towards MLD. But in otherwise gray matter disorder, usually you have microcephaly. Okay, what about Niemann-Pick disease?
Sir, we can differentiate because there is no any presence of any hepatosplenomegaly, sir. As well as the ataxic features has been there, or its presentation is late, sir.
Niemann-Pick disease, do they have hepatosplenomegaly?
Yes, sir, yes.
In this child, do you have this?
No, sir, that's why.
Okay, so that also looks little unlikely. Sir, Bala sir.
Yeah, two or three things. The earlier recommendation to distinguish white and gray matter degenerative disease is now nearly gone. Though traditionally in the exam they ask In this child, if you ask me whether this is a gray matter problem or a white matter problem, it's very difficult to clearly distinguish in this child, but there seems to be a mixture of both gray and white matter involvement. For the simple reason, child is aphasic, child is intellectually impaired, cognition is impaired, and is not really very spastic, is only hypotonic, indicating it's a cortical hypotonia. The reflexes are present as per your findings. So this looks more like a gray matter degenerate disease than a white matter one. So if I were to put the diagnostic possibilities, the first diagnosis I would have put is probably neuronal ceroid lipofuscinosis, followed by maybe metachromatic leukodystrophy, and of course mitochondrial disorder. Even though it is a female, I would have definitely put it as male as a possibility. These are the three things that I would have put. In addition to these three diagnoses, even though HIV screening is done routinely in India, the possibility of intrauterine infection like HIV is not ruled out, because the infant is quite normal in the first year. Things started later. That can happen in perinatal HIV infection. In fact, the neurological manifestations of HIV are unique and diverse. They can present with progressive multifocal leukoencephalopathy with microcephaly resembling even cerebral palsy, right? Or they can present with microcephaly with developmental delay, or they can develop some secondary infection like cryptococcal meningitis, tuberculous meningitis, right? Herpes simplex meningitis, difficult to treat. They can present like that. So that is one possibility you have to consider. I don't think I would consider Niemann-Pick's or Gaucher's in the absence of hepatosplenomegaly. Mitochondrial disease, I would definitely consider. Adrenoleukodystrophy, female child, very young, no manifestations of adrenal insufficiency, I would not be considering. These are my thoughts at this point of time. Okay? Then, suppose you are given this case in the exam, I would ask you, how do you evaluate this child? How will you evaluate, and what did you do for this child?
Sir, first of all, we have to go for the neuroimaging, sir, like MR brain with
Neuroimaging. You have the pictures of neuroimaging of this child?
Yes.
If you have, show me. The
Sir, it
pictures.
shows the. Sir, I have only put the report, sir.
Oh, what does the read out the report? The letters are so small. What did they? Yeah, please. What does it say? At least briefly tell us. Suggestive leukodystrophy, metachromatic leukodystrophy, is it?
It denotes a symmetrical hyperintensity is noted involving bilateral posterior periventricular white matter adjacent with the deep white matter with the subcortical fibers involvement. There has been hyperintensity shown in the cortical spinal tract also, posterior limb of the internal capsule also, with cerebral peduncles, pons, medullary pyramids also. So overall pattern shows the continuous tract involvement. With a prominent corticospinal tract involvement suggestive of metachromatic leukodystrophy, sir.
Okay,
so the first
fine,
thing we can
fine. You don't have the pictures?
Sir, I have not put, sir.
Okay, it's okay. What other investigations will you consider in this child?
Then other I have done, sir, MRI brain spectroscopy, sir. It will show us what are the abnormal electrolyte, if any peak will there. So that will represents.
Okay. What other investigations will you do? Of course, MRI you have already done. What other investigations will you do in a child with neurodegeneration? There are few things you
Then
should do. One is to get a good
then we can go for
ophthalmological
the
exam.
enzyme assays also, sir.
First
Like
thing is you must complete the basic test, man.
yes,
Must do an ophthalmological evaluation, hearing, BERA test may be required or you have to do an audiogram, impedance audiogram in this child. Third, you should do a complete hemogram to look for any clues like A beta lipoproteinemia, some findings in the peripheral smear. Okay. Then third, you must do a liver function test and renal function test to exclude, Gotch's, Niemann-Pick's, etc. Okay. And additions for adrenal leukodystrophy, as you mentioned. Then you should do a rule out hypothyroidism by doing a free T4 and TSH, right? You should do HIV in this child. And then,
ABG also.
electrolytes. These basic tests should be done. Then, of course, MRI, and depending on the MRI findings, enzyme assays, and of course, nowadays, all these cases we diagnose by whole genome sequencing. Okay, whole exome sequence, WES, is try to ask for to find out the exact diagnosis. If necessary, we do an enzyme assay. Okay, that's how you diagnose, right? Anything else
Yes.
you have to present? You have with you?
Then, sir, we have also performed this spectroscopy, but it didn't show any peak lactates or choline. While nerve conduction velocity has been also.
Wait. I do not know the details of how to interpret these spectroscopy. It's not my area.
Yes, sir. So in spectroscopy, like if any presence of lactate peak has been there, so it represents like mitochondrial disease or the Lees disease, sir. Like choline represents any enzyme abnormality related to our energy turnover, sir. So that will represent that any cortical dissociation has been there or not. Then, sir, we have performed the nerve conduction velocity also, sir. There has been presence of the decreased velocities of both motor nerves as well as sensory. So that is representing the demyelination, sir. Yes, sir. Then they have been actually suggested to go for the enzyme assays, basically aryl sulfatase.
Nowadays, enzyme assays are not done for these cases. These cases, straight away, they do a whole exome sequencing and diagnose, right? Is a better way to diagnose this. Though enzyme assays are done in some centers, nowadays we have stopped doing it. Straight away, whole exome sequence, you'll get a report in 2 to 4 weeks, right? Go ahead. Next.
Thank you.
Okay. Now, if you have Naresh, I have a presentation on neuroregression, frequently asked questions. I can ask some questions for about, now what's the time? It's already 10, then it's not necessary. Okay, right. Very good presentation. Any comments from Naresh?
Yes. And lastly, can you tell me what are some of the white matter disorders which you can consider? Few you have described, any other conditions? Predominantly white matter disorders, neurodegeneration.
So white matter disorders like metachromatic leukodystrophies, adrenal leukodystrophies, or Canavan disease can be there, sir.
Even Canavan, Alexander, even Gravis, they are significant white matter involvement. Okay. I think that's also time is up. It's 10:15 almost. Very nice presentation, Dr. Meenakshi. And good case also.
Excellent presentation. Well done. If you do like this, you will get distinction in the exam. Okay. Any other comments from the audience or from senior professors? Dr. Sandeep?
Sandeep may wind up now. Otherwise.
Well done, Meenakshi. You did brilliantly, right? All the best to you. You are a first year resident or a second year resident?
Third year.
Third year.
Final year. When is your exam?
Sir, next month, sir, PU has been there on 20.
You're a DNB or an MD postgraduate?
Sir, MD.
Superb. Well done. Keep it up. You'll easily pass with distinction. Fine. Over to Sandeep.
Yeah, thank you, sir. So, as we conclude this session of PG Clinics today, I extend sincere vote of thanks. First, our deepest gratitude to our eminent experts, Dr. Balasubramanian sir, Dr. Motwani sir, for their invaluable time, their clinical insights, and for simplifying this complex concept. And also, we must congratulate our presenter, Dr. Meenakshi Thakur. Preparing and presenting a case before distinguished panel takes immense efforts, and you did an excellent job. And lastly, I thank all the academy members and postgraduate students for their active participation. We also thank Team Juventus for their support, and thank you all. Thank you very much. Thanks once.
Thank you. Thank you, sir. Bala sir, thank you, sir.
Thank you.
Thank you.
Good night, sir.
My WhatsApp is not working. That's why I have to.
No issues,
No
sir. No
problem,
issues.
sir. No problem.
Tomorrow
Not-
morning, I'll have to set it right. Okay, thank you.
Thank you, sir.
Okay. Thank you, sir.
Good night, everyone. Thank you.
Good night.